Hello everyone and welcome to today's webinar on reproductive coercion, which will be presented by Liz Price from Children by Choice. I would like to thank the Brisbane South PHN, CQ University and the Queensland Government for making this webinar possible today. Before we begin, I would like to acknowledge the traditional owners of the lands on which we meet today and pay my respects to the elders, past, present and emerging. I pay respect and acknowledge the important role of Aboriginal and Torres Strait Islander peoples and that they play in responding to domestic and family violence. I will run through a couple of frequently asked questions for today's webinar. We would love for you to get involved in the webinar by asking questions in the chat function located on your screen. The webinar will be recorded and made available on our website, noviolence.org.au. If you experience any technical difficulties, please contact your internal IT support staff, or alternatively, you can dial in via phone using the number provided on your webinar confirmation email. Finally, due to high number of participants, we are unable to provide certificates of attendance for this webinar. I would now like to introduce today's presenter, Liz Price. Liz is an experienced social worker who has been part of the counselling team at Children by Choice for the past 8 years. She has a particular interest in the intersection between domestic violence and sexual reproductive health. Liz is committed to enhancing the capacity of health practitioners to identify and respond to women experiencing reproductive coercion. I will now hand over to Liz and I hope that you enjoy this presentation.
Hello to you all out there in the lands of Queensland. It's a cold, grey day here. I hope that you're enjoying some warmth, even if it's the warmth of human company, as we sit today. Thanks so much for the warm welcome and for making space in the training agenda for today's presentation. I appreciate all of the work that the Queensland Centre for Domestic and Family Violence Research folk have done in supporting this important area of practice for us. And as Rhiannon mentioned, today's webinar is about reproductive health impacts of domestic violence, exploring a healthcare practitioner's role in supporting women's reproductive autonomy. There we go. I'd like to echo Rhiannon's acknowledgement of country and pay particular respect to the people of the Turrbal and Jagera lands of where I live and work, and add a little bit to the introduction that Rhiannon offered. I remember starting my work at Children by Choice some 8 and a bit years ago now, having come from a domestic violence space and thinking that I was leaving that space. Very naive thought of mine, but it wasn't long in that role before I became really well aware that I was stepping as deep into the work of working with women around violence as the place I'd come from. And women's stories have been the place that journey started in helping me to understand the intersection between unplanned pregnancy, abortion and domestic violence, and has certainly helped me to get my head around the issues of reproductive coercion, what they mean for my practice and the implications for the broader service system that we all engage with, and today that's what we're here to explore some more. During this session, you may find me moving between the phrase intimate partner violence and domestic violence, recognising that issues of reproductive coercion can be found in those both those spaces. And you may also hear me move between the language woman and pregnant person, in acknowledgement that not all people who are capable of becoming pregnant may identify specifically as women. Today's topic, like any time when we get together to talk about domestic violence, may be triggering, and you may experience some impact of the content today on your sense of well-being. And I urge you to take care, to do something kind and nourishing for yourselves, as well as reach out to another colleague or loved one if you're feeling distressed by today's content. So just a really quick overview of today. We will be briefly looking at the sexual and reproductive health impacts of domestic violence and funneling down then to look at the patterns and prevalence of unplanned pregnancy and abortion in those affected by domestic violence. We're going to dig into reproductive coercion as a perpetrator practice to understand its strategies and its intentions. and the role that it plays in the overrepresentation of women experiencing violence and those facing unplanned pregnancy and abortion. And we're going to look at the way that healthcare practitioners can support women subjected to these experiences in the work that they do. And through that conversation, I'll also try to present to you some of the practitioner resources that we've developed around these issues and the way that they fit into the practice for you. I'm not going to labour too much over setting the scene today, but ask you just to remember as we move forward with the content that half of all pregnancies are unplanned, and that almost 1 in 4 women in violent relationships will experience violence for the first time in pregnancy. So we begin to see that over the intersection of unplanned pregnancy and violence already as we start to think about that really big picture. Specifically though, when we're thinking about the impacts of sexual and reproductive health, we're thinking about a number of things. What we see in women experiencing intimate partner violence and domestic violence is an overrepresentation in those presenting with sexually transmitted infections and urinary tract infections, and also an overrepresentation of those presenting with miscarriage. Recent work done around emergency department presentations shows us that pregnant women are much more likely to be presenting to emergency departments with injuries to the trunk, for example. We begin to understand the ways in which physical violence plays a role in the overrepresentation of those women experiencing miscarriage. From all of this then, it's no surprise that those women may be presenting with issues of fertility at both ends of the spectrum. These are women who may go on to develop infertility issues on account of the cumulative effect of STIs, UTIs and miscarriages, and at the other end of the spectrum are also women who may be subjected to rapid repeat pregnancies. In amongst all of this as well, and please let's not forget this one, women also report reduced sexual functioning. So even the act of sex brings no pleasure to their lives. And then our work sees us engaging with those facing unplanned pregnancy and accessing, seeking our support to access abortion or post-abortion support. And again, the overrepresentation of those women experiencing violence in amongst those with unplanned pregnancy and abortion. Let's drill down into that a little further. What we know is that unplanned pregnancies are 2 to 3 times more likely to be associated with violence than planned pregnancies, and that women who experience domestic violence are 2 to 3 times more likely to have an abortion than women who do not report experiencing violence and control. This is regardless of whether the violence is historical, recent or current. So in populations of women reporting historical abuse, we see up to 2 times more likely to be experiencing an unplanned pregnancy and an abortion. And where the violence is recent or current, up to 3 times more likely to be presenting around unplanned pregnancy and abortion. So what we can take from this is that the impacts, the domestic violence impacts on sexual and reproductive health follow the woman after the violence has ended. And this has implications for us both in terms of how we screen and respond to these women. So let's have a look then. It's hardly surprising for us then, knowing that women experiencing intimate partner violence and control are overrepresented in those experiencing unplanned pregnancy and abortion. So it's hardly surprising for us to then notice some very obvious patterns around contraceptive use. So we know that women experiencing and subjected to intimate partner violence are much less likely to use contraception than women who are not subjected to this violence, and that for many women this trend is compounded by their alcohol and drug use. So we see women reaching out to things like alcohol and drug use to survive and ameliorate the impacts of domestic violence. This further compromises the level of control they have over their own reproductive capacities. The research also shows us that contraception request can be experienced as a trigger for violence, and this is really important information for us to understand and has significant implications for the types of contraceptive use that we might be suggesting or promoting for women living in relationships where there are violence or where there's been historical violence present. So we know then that the perception of the fear of potential violence can limit a woman's ability and confidence to negotiate condom use just as much as it can for those who are living with current violence. And this is certainly even more pronounced in women who are sexually coerced. So if there's been a request for contraception that's then been followed up by an experience of or is subjected to forced unprotected sex, then that capacity to negotiate future contraception is even more impacted by that specific sexual violence response to that request. Okay. So on the flip side of that, again, in news that surprises absolutely nobody, the research shows some very clear patterns amongst male perpetrators of intimate partner violence, with them being much less likely to be up for condom use. So they're likely to perceive a request for that quite negatively, and have sometimes fairly violent response to that. And they're also less likely to use condoms or to be more inconsistent in their use of condoms, even if they have multiple sexual partners. So they're engaging in quite high levels of risk-taking behaviour in relation to the kinds of sex that they're having, where they're known to be perpetrators of violence. So here we have then women reporting, concern about trying to negotiate condom use at the time of sex and other forms of contraception out of fear, and on the other side we see perpetrators' negative views of these requests, and so this becomes quite a dynamic mix for women living in these contexts. Okay, so what's driving all of this? And I think there are several drivers here. I think sometimes this practice of viewing contraceptive requests negatively, or the overrepresentation of women experiencing the intimate partner violence, facing unplanned pregnancy and abortion, can be just about male perpetrators placing their own sexual needs, their own sexual pleasure at the centre of the sexual act. But we also know from the stories that women have shared with us and the international research that sometimes this is an intentional practice on the behalf of perpetrators, something that we've come to term reproductive coercion. When I first started hearing stories from women years ago, one of the first stories that I ever heard was a story from a woman who'd been dating this guy for about 3 months, and he'd very soon encouraged her to move in with him. And upon moving in with him, he began to destroy her oral contraceptive pills by pushing them out of the blister pack and flushing them down the toilet. And then, hid her car keys so she could not go out and access emergency contraception afterwards. So in a very short space of time, she went from starting a relationship with this man to cohabiting with him, and then an unplanned pregnancy came in play. And this one really stands out for me because I think it was the first story that a woman shared with me in which the intentionality of those practices could not be denied. And once hearing that story, it became imperative that I get my head around what this issue was all about and what that meant for me as a counsellor, as well as what it meant for the other service systems that this woman was going to be intersecting with through seeking support around this unplanned pregnancy. And through our research, we've developed our working definition of reproductive coercion, which is any perpetrator behaviour aimed at establishing and maintaining power and control over a person who they are, were, or seek to be in a relationship with by interfering with their reproductive autonomy, by denying her control, decision-making and access to options regarding reproductive health choices. So let's just unpack that definition a little bit if we could. We see reproductive coercion being disclosed by women across relationship types. So some women may say that they're just in a friends with benefit relationship with the person, but they feel like that other person is wanting to elevate the status of the relationship. They may be in an established relationship where this is a practice, or they may have recently separated from this person, and the coercion of a pregnancy is used as a strategy to try to re-engage and reinstate that relationship that's ended. So relationship status does not predict the vulnerability of the woman to reproductive coercion. We need to be attending to this issue regardless of the relationship status that women are reporting to us. In terms of establishing and maintaining parent control, we do hear from women where reproductive coercion is the first thing that they've noticed and named in relation to violence and control. And for other women, it's part of a pattern of violence and control. So we believe that possibly what's happening for some women is that reproductive coercion is a gateway to establishing parent control in the relationship, where we know that parent control do best in relationships where there's some level of commitment. And so elevating the status of a pregnancy, a relationship through a pregnancy, through a coerced pregnancy, can be a way of establishing commitment in a relationship in which then other forms of violence and control can take place. And again, this has implications for how we screen and respond. We're not just going to be screening those women who are disclosing other forms of reproductive coercion. In any pregnancy care setting, in any contraceptive care setting, we're also wanting to be asking women when no other forms of violence and control are being disclosed. Okay. So what I want to do now is talk a little bit more about the sorts of strategies that a perpetrator may use. And I think it's really helpful to hold these three things in our heads during our conversations with women. It helps us to think about how we ask questions that unpack her experience across time to establish patterns of behaviour by the perpetrator. We see three broad categories over time: pressure to become pregnant, contraceptive sabotage, and pregnancy outcome control. Pregnancy pressure can take many forms, but I'd like to kind of share some little vignettes from women's stories so that I can bring some life to that. I think one of the ones that really stands out for me is a young woman telling me that the guy that she was in a relationship with would constantly accuse her of infidelity. And he would say to her, you just don't want to become pregnant to me because you're too busy screwing around with all those other guys. And you know, if you're pregnant, no one else but me is going to want to have sex with you. And that's why you're not prepared to have a baby with me. And he was relentless about this. It was something that he said to her on a very regular basis. And so she thought that if she agreed to go ahead with the pregnancy, that he may let up on that. But of course, what happened was the strategies began to shift and change now that the pregnancy was in play. So she yielded to pressure over time to become pregnant when she didn't want to or didn't feel right about that. We also, of course, in the context that we work in, hear many stories about contraceptive sabotage, and that first story I've shared with you has a couple of examples there. So the destruction of oral contraceptive pills, so the destruction of devices and drugs used for the purposes of contraception being a regular feature, and the denial of access to other forms of medical intervention, such as turning up to the chemist, driving to the chemist with your key card, to go and buy emergency contraception after unprotected intercourse, denial to access to services, to medical services for, the 12-week depot injection. And unfortunately, on some occasions, we do hear stories in extreme contexts of physical violence around forcible removal of implant rods, as well as the forcible removal of IUDs, which is both a physical assault and a sexual assault at the same time. So a raft of contraceptive sabotage strategies, not just that of stealthing, which is the one that does seem to make its way into the media most often. And you'd be familiar with stealthing, that the removal of the condom during sex, after sex, the conditions of sex have been negotiated. So yes, I'll have sex with you, let's use a condom, and then the condom being removed unbeknownst to the woman during the course of intercourse. So contraceptive sabotage can take a whole raft of strategies, from drawing on other forms of domestic violence, which are listed in the Domestic Violence Act. So, economic control, physical abuse, sexual abuse, financial control, destruction of property, etc. So reproductive coercion sits across that gamut of different forms of domestic violence. And then there's pregnancy outcome control. And again, this is one that's very common for us in the context of our work around unplanned pregnancy, but doesn't necessarily make it into some of the research that's done in other contexts. So we do often hear stories from women around perpetrators' attempts to prevent them from accessing an abortion, such as promising to pay for the abortion and then just not turning up with the cash on the day, sending threatening or emotionally manipulative messages to the woman on the day of her appointment, threats around what they'll do to them physically if they do have an abortion, etc. And then, of course, for some women, there's also the experience of forced abortion, and we'll go on to talk about forced pregnancy versus forced abortion a little bit later in today's presentation. One of the resources that will be made available to you after this webinar is one called Prompt Questions for Exploring Women's Experiences of Reproductive Coercion. And each of those categories of perpetrator behaviour, pregnancy pressure, contraceptive sabotage and pregnancy outcome, are listed on that resource with half a dozen questions or so that you can use as a way of opening up and exploring a woman's experience around these things, such as from pregnancy pressure, do you feel okay about talking to your partner about if or when you might want to become pregnant? From contraceptive sabotage, have you ever felt you needed to hide contraception from your sexual partner so he wouldn't get you pregnant? And from pregnancy outcome control, has anyone ever made you feel afraid or threatened consequences if you didn't continue your pregnancy? So there's some examples from each of those categories. So why might it be in a perpetrator's interest to coerce a pregnancy and to coerce motherhood? What's their agenda in there? I think about that in two distinct ways. Both the pregnancy itself is a form of control, as well as motherhood being a form of control. So it creates physical vulnerability, and quite literally it's much more difficult to get off the couch when you're heavily pregnant, much more physically difficult to go. It reinforces the perpetrator as the protector, so it really entrenches those gendered roles of protector, provider and nurturer. And these things contribute to make it harder to leave. Even if women have left, the ongoing, the child that might result from a forced pregnancy establishes and maintains a permanent connection between the woman regardless. And we hear many of those stories of the ways in which institutional abuse through the family court, for example, unfolds as a consequence of that. The ways in which abuse can happen at the time of contact and handover, and the ways in which the child becomes used as a tool for ongoing violence. From early parenting, that a woman's time is significantly restricted outside of the home, and it certainly entrenches her economic dependence upon him. And he may believe that it reduces her attractiveness to others, further entrenching her in that relationship. There's a lifetime of control that can be achieved by the perpetrator through forced motherhood, and certainly during the pregnancy can also be a form of control. We know that that violence can start and sometimes get worse in pregnancy for some women, but we also know in other instances that violence may taper off, and some of the research that's done with perpetrators around that reveals that the reason that the other strategies are not being drawn upon is that the pregnancy itself becomes the form of control for them during that time, which confirms for us the stories that we share with us. So on the flip side then, what might be the perpetrator's agenda in relation to coerced termination? I'll just try and move on. Okay. Again, it's about control, but it's about control from a different point of view. So a coerced abortion can maintain the focus of the relationship on the perpetrator's needs and wants. And we certainly see in some cultural and religious communities that forcing a woman to go against her spiritual or religious beliefs can be a form of spiritual abuse. And then, particularly in those communities, the threats of disclosure about the abortion can be used as a threat to further isolate her. If you tell anybody about this abortion, then I'll let everybody know, which makes it much more difficult for her to remain connected to her community and maybe ostracised by some cultural communities. It also denies the woman the positive attention that the pregnancy and the woman may receive during pregnancy and parenthood. So it denies her that experience, that potentially empowering experience of both pregnancy and parenthood. So we can see in both directions the perpetrator's agenda, either through coerced pregnancy and motherhood or through coerced abortion. So what does the research then tell us about the impact of a woman being able to access an abortion in context of violence? So we turn to some of the, along with the stories that women obviously share with us every day, where they're saying, if I'm connected to this guy, it's going to be hell for me, he'll be ongoingly violent. The good solid research that we turn to is the Turnaway study in the United States. It's a longitudinal study that's followed a cohort of, I can never remember whether it's 5,000 women over 3 years or 3,000 women over 5 years, but it's a big study over a number of years, and they followed a group of women and looked at the impact of accessing an abortion versus not accessing an abortion over a number of psychosocial measures, one of those being violence, and the others were poverty and child development, but we're focused on violence today. And they did matched pair studies. So in the United States, a little bit like Australia, the gestational cutoff in the various jurisdictions changes from one state to another. So they recruited a number of women, some of whom were just under the gestational threshold for an abortion in their jurisdiction, and some who were just over the gestational threshold for an abortion in their system. So their gestations were very close together, only a matter of a few days apart, and across a number of gestational thresholds across different jurisdictions. And they followed those women over time to look at the impact of being able to access an abortion versus being turned away from an abortion facility because of their gestation. Hence it's called the Turnaway study. And in news that surprises no one, those women who were able to access an abortion went on to experience lower levels of violence over time than women who were turned away and forced to continue their pregnancy. The research and our work with women also confirms for us that the decisions that they make in relation to unplanned pregnancies are based on issues of relationship and concerns about ongoing violence, concerns about their connection to the perpetrator, as well as about their concerns about the impact of the violence on the resultant child. So they're right. The research confirms what women know about their own lives in that regard. So we know for many women that access to an abortion may increase her safety, and so it's important for us to consider that in terms of the ways that we respond to women seeking access to both contraception and to abortion. So who are the women that healthcare practitioners will see that may be experiencing reproductive coercion? And some of this is drawn from our research as well as the international research, and we've recently published a paper that was published in the International Journal of Intimate Partner Violence on these issues. And our stats do pretty much align with some of the other international research, largely coming out of the US. So what we know from our research and that research is that about 1 in 3 women who experience domestic violence will also be disclosing reproductive coercion as part of that experience. So 1 in 9 women who contact our service will experience some form of reproductive coercion. As I mentioned earlier, it will also be some women who've not experienced any other forms of domestic violence or haven't named and noticed other forms of domestic violence other than reproductive coercion. And I mentioned the named and noticed because I think sometimes, there's nothing more obvious than two blue lines on a stick to let you know that a perpetrator's strategy has been successful. It's much easier to manage, for example, than the slow erosion of confidence or self-worth. So it can be something that can be quite easily named and noticed or noticed and named. Our data also tells us that women from culturally and linguistically diverse backgrounds are likely to be overrepresented in those reporting reporting reproductive coercion, and also women who identify as Aboriginal and Torres Strait Islander. Some of our early, we've only just recently started to collect data on the direction of the reproductive coercion that women were experiencing. So the publication that's just come out just talks about reproductive coercion, the presence or absence of that. But more recently, we've started to capture data that allows us to look at whether the person's coerced to abortion or whether they're coerced to pregnancy and parenting. And some interesting trends are starting to emerge across the cultural groups in that regard, where culturally and linguistically diverse women are more likely to be disclosing coerced abortion, and Aboriginal and Torres Strait Islander women are more likely to be disclosing coercion towards pregnancy. I think that touches on some of the drivers I was talking about earlier about what the perpetrator's intentions may be, perhaps using abortion as a way of spiritually abusing and socially isolating a woman where her choice would not be supported, where abortion would not be supported culturally or religiously. And I think there's still a lot more work for us to do to understand the nuanced experiences of those women, along with the experiences of Aboriginal and Torres Strait Islander women who are reporting reproductive coercion towards pregnancy and abortion at greater rates than non-Aboriginal and Torres Strait Islander women. I mentioned earlier that our initial data is starting to show us the balance of trends there. So as healthcare practitioners, about 80% of the women experiencing reproductive coercion will be disclosing coercion towards pregnancy and motherhood, with about 20% of women presenting to you potentially struggling to cope after a coerced abortion. So 1 in every 5 with coerced abortion, 4 in every 5 for coerced pregnancy and potentially motherhood. And some people are surprised by that, but when we think about the perpetrator intentions and why it might be in the interest of a perpetrator, we can see that coerced pregnancy and motherhood has far-reaching consequences in terms of control over the woman's lifetime than potentially a coerced abortion does. So what then might a healthcare practitioner's role be in responding to the needs of people subjected to reproductive coercion? I'm just going to do a quick time check to see how we're going there. Not too bad. So broadly, it's going to be about contraceptive counselling sensitive to issues of violence and control, facilitating access to contraception and access to abortion, facilitating and supporting access to abortion. I know that people tell you this all the time, but the implications for these things are that you need to ensure that you see the woman on her own for at least a part of each consultation. Because we know that disclosure doesn't necessarily happen the first time we ask, we need to make sure that we're making repeat opportunities for women to disclose and to be asking directly about that. In our work with the abortion clinics, one of the really simple things that we've done to support nurses around that is to just put a sign up that says something to the effect of, it is the policy of this medical practice to see patients on their own for some medical consultations and treatments. Thank you for your cooperation with this. And then we can point to that sign and we can show that this is standard protocol for everybody who comes to this clinic. We're not singling out particular women's partners for that purpose. So this can actually then allow a woman to make some advanced preparations for making use of an opportunity to disclose. Knowing that she'll have an opportunity alone with you can get her thinking about how she might make use of that opportunity. And being able to linger around this conversation and to ask directly is a really important thing for us to be able to do. And then to be acknowledging that disclosure, to be letting people know that it could be pretty tricky to be talking about this out loud, or letting somebody know for the first time about these experiences. We also need to validate and normalise their experiences, to let them know that 1 in 9 women may be experiencing such things. And this is becoming, as a community, we're becoming much more aware of what we call reproductive coercion, giving it that name to validate her private experience with a name that's publicly researched about. And then we're modifying our care in terms of taking extra care and precautions around our contraceptive counselling and abortion access advocacy where required. So as I said, allow time to thoroughly explore this issue. Sometimes it can be really hard for people to put words around their experience and to get started with that. And what this means is we sometimes come to a dead end or a stumbling block in our contraceptive counselling conversation. This might indicate that we're bumping into the operations of power and control in the woman's relationship. What have you thought about future contraceptions? Oh, I'm not sure, I'm not going to have any. I don't know. Might suggest there's something else operating, and we might need to ask directly about that. We might ask, does your partner ever get in the way of you using contraception, or how comfortable are you exploring this with them? We can always do what I call going sideways. We can say something like, sometimes women find it hard to talk about contraception with their sexual partners, or they might prefer to use a contraceptive they didn't know about. Do you relate to that at all? So she can just answer with a yes or a no, rather than having to find her own words to put around that. If we can't get past dead ends in contraceptive counselling, there's a couple of things I suggest that we do. One of the other resources that we've shared with you is a little tiny discreet pamphlet that's small enough to fit inside a wallet that's called Who Controls Pregnancy Decision Making in Your Relationship? We could pass a copy of that to the woman and say, this might not relate to you, but it might relate to somebody else that you know. It helps us think about who controls pregnancy decision-making in our relationship. And she may go away and do some more thinking about her own experiences based on this leaflet, or she might pop it in the bin, or she might pass it on to somebody else. But all of those things are okay. The other thing I think it means, and this is some of what we've been talking to abortion clinics about, is making sure that we attend to emergency contraceptive as an important response. So if there's no plan for future contraception, emergency contraception is really important. And I never assume that women have knowledge about emergency contraception options or how to go about accessing it. Many women do, but a number of women don't. So taking the time to actually stop and do a little bit of education around that. I'm just flicking on to the next slide. I'll just go back. Just a reminder then, the 3 forms of emergency contraception that are out there. There's our good old friend levonorgestrel, the old oral emergency contraceptive that's effective up to about 3 days post-sex. And there's now also the all-crystal acetate that's available over the chemist without script, which is more effective than the levonorgestrel over a longer period of time, up to 5 days after unprotected sex. And if you happen to be an IUD inserter, don't forget that copper IUD can be used as a form of emergency contraception as well. So, moving on then, if we are then able to unpack that conversation with women a little bit more about the barriers to contraception, it can be really important for us to discern whether this is really just that the guy's wanting to censor his own sexual pleasure, or she's anxious about his reaction to a request for contraception, or whether that's about reproductive coercion. And again, a simple question to invite her to think about that might be something like, do you think he's trying to get you pregnant, or is it more the worry of his reaction to talking about contraception? So she says the second one, and I use that as an example because sometimes when I'm trying to work really hard with women, what do you think's going on here? They're not really sure. I might then offer that choice. Is it this or is it that? And sometimes they can't even say, I'm really nervous about asking about contraception. They might just say, oh, it's the second one. So if they say it's the second one, but that's fine. We don't need to require them to put any other words around that. Make sure we're routinely screening for pregnancy. Make sure we're offering forms of contraception that don't require negotiation at the time of sex. And we're thinking there around things like withdrawal, fertility awareness methods that might require her to be working around fertile times, trying to navigate non-penis and vagina sex at those times, diaphragms, withdrawal, condoms. Those are the things that need to be negotiated each and every time. So we're going to be wanting to work around those options for her. Now, I know sometimes people will say, yeah, but condoms and STIs, and I hear you about that, but I think we can't change that person's confidence in terms of negotiating the conditions of sex in one appointment. What we can do is take a harm minimisation approach and do regular STI testing and ensure at least she's got control over if and when she falls pregnant. So it's a harm minimisation approach to recognising that. And lots of the school-based health nurses have been kind of, really taking stock of this information and thinking about the message that they're giving young women all the time about condoms, 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 and seeing those people coming back for STI testing time and time again, even though they're giving the condom message, and starting to think about, what's getting in the way there. So consider referral to domestic or sexual violence counselling, the school health nurse, the support around that underlying issue that may be getting in the way of negotiating sex on their own time, on their own terms. And as I mentioned again, education on oral emergency contraception, considering advanced supply for women who may be doing it tough in the trenches and be prevented from accessing emergency contraception after an event of unprotected sex. And if it's about reproductive coercion, we're thinking about assisting women to access contraception less vulnerable to detection and sabotage. And I will at this time point out one of the other resources that we're making available to you. It's a trifold resource that you can download as a PDF and glue together, but that's all a bit too art and craft for some of us. We've got plenty of spare copies of that trifold resource still available. So if you want to get in contact with us after this webinar, I'm more than happy to send some hard copy resources to you. What's really great about this is it's got a number of practical applications. You can actually you can use it as a poster on the wall of the women's only spaces in your clinical service, and you can use it as a desktop resource. So it's a chart that looks at all of the forms of contraception that are available to us here in Australia, with the usual information about what it is and how it works, the advantages and disadvantages. But we've also gathered together information about whether somebody will know that whether they're using it and whether somebody could tamper with it. So it's very specific information around the advantages and disadvantages in terms of the discretion and sabotageability. I don't think that's a word, but I'm going to use it anyway. The sabotageability of a particular form of contraception. Now, people ask me, what's the best form of contraception for a woman living under, being subjected to reproductive coercion? And my answer to that is we really need to explore her unique circumstances, because we know that all kinds of different strategies of contraceptive sabotage can be at play. So her unique circumstances will help shape up a response that's safe and appropriate for her. Now, sometimes women won't necessarily be able to share all of what's going on for them for you to do that matching. But if we're providing information about the advantages and disadvantages and the detectability and tamperability of forms of contraception, she can use the knowledge she has about her own circumstances to do that matching work. If we're fortunate enough that she can disclose some of that, we can have some much more nuanced conversations with her about suitable options. And again, I remind you that we know that patterns of violence change, so encourage them to come back if she's at all concerned about the safety and suitability of what she's chosen. Now, what we want to do now then is look at some of those specific strategies that perpetrators may use to monitor if and what a woman is using by way of contraception, and think about what that might mean for matching. So yes, we know that some women's Medicare and pharmaceutical benefit scheme records are being monitored through their MyGov account. They don't necessarily have control over that. And again, if we're thinking about my health record, thinking about whether that might be also something that's vulnerable. So what do we record and what don't we? So for example, what springs to mind then is something like a copper IUD, which actually isn't on the pharmaceutical benefit scheme. So if that's being provided, there won't necessarily be a record of that on her record. If they're likely to restrict and monitor access to healthcare professionals, we're certainly wanting to think about the most long-acting form of reversible contraception. We'd be wanting to steer away perhaps from something like Depo, for example, where she's going to need to get out regularly every 12 weeks, give or take, for her next injection. If they're likely to monitor menstruation and fertility patterns, so we're thinking about things like the oral contraceptive pill where regular menstruation still occurs, or the copper IUD, which is a highly effective long-term contraceptive, but menstruation and ovulation still continue if those things are being specifically monitored. Likely to be engaging in severe physical assault, so we may want to work around something like the implant rod. And I have talked about the forcible removal of IUDs, but some practitioners are in the habit of trimming the strings flush with the cervical canal such that they can't be detected or forcibly removed by anybody other than somebody with training. Now then people say to me, yeah, but it makes them pretty tricky to get out. And again, let's talk about harm minimisation. If we're talking about a 10-year copper IUD and we're talking about one tricky IUD removal over a 10-year period versus all of the other things that can unfold for that woman over a 10-year period, whether that's, a couple of miscarriages, several abortions and a couple of unwanted live births in a 10-year period, I say from a harm minimisation point of view, a tricky IUD removal is worth it if it's going to prevent a whole bunch of other stuff happening for her. So again, if we're thinking about whether the person's going to be actively searching for the use of contraceptive drugs and devices, we might be ruling out the implant rod, we might be ruling out the diaphragm, we might be ruling out IUDs if we're not able to have those strings cut. Where it does take my head, and a contraceptive I've had to make friends with again during this process has been Depo, where with Depo, once that's in, it can't be detected and can't be found can't be tampered with, except for preventing the woman from going back for that 12-week shot. And of course, we're not going to be recommending any form of contraception that's going to need to be negotiated at time of sex, where we know there's going to be rape or other forms of sexual violence. And when I was proofreading the trifold resource with a domestic violence worker, I was just seeking her feedback to make sure I got my information straight. She did a quick audit of the women on her caseload, and she was alarmed to realise that 75% of them were relying on withdrawal as a method of contraception. If you can think of one that gives the man more control over her fertility than that, then please let me know. So, a couple of other things to keep in mind. If you're needing to resolve her contraceptive need in a single contact, we're thinking about those quick start protocols for implant or IUD insertion. If the woman's cohabiting, certainly that's going to restrict things like the pill, for example, and the impact of violence and control on the woman's daily routine. So she might not be being, reproductively coerced, but remembering to take the mini pill at the same time each day, if she's doing it tough, maybe just beyond what she can manage. So thinking about that. Okay. The other things that you can do are to know your referral points for licensed services in your area, so we can make sure that we're facilitating swift access to long-acting reversible contraception for women where that's appropriate. And if you don't have it currently within scope of practice, please consider becoming a licensed inserter, particularly if you're in a regional remote area where there aren't a large number of inserters. Know the protocols for quick start initiation of LARCs, and consider offering the insertion of LARC as a bulk billed service, especially for women at risk. I mentioned the results to help you with all of that, and that's a little infographic picture of the front and back of that, so you'll recognise it in the mail when it arrives. Okay. Sorry, I just feel like I've skipped forward there a little bit, but perhaps I haven't. Okay. So let's move on to talking about facilitating abortion access. I'm mindful we've only got 7 minutes left and I do want to leave time for questions. I hope you're all aware that abortion has been decriminalised in Queensland and now is available in the public system in some health and hospital service districts. So you can use your Google fingers and check in with your local health and hospital service to see what the pathways for abortion access may be for women in your area. So if you're dealing with women who are experiencing violence, who cannot afford a private clinic abortion, we'd certainly be recommending that you facilitate a referral into the public system. If you're meeting any roadblocks in your health and hospital service district in relation to those referrals, we'd like to hear about it so we can continue our big picture advocacy work to ensure equity of access to abortion for all women across Queensland. The other things that you can do to facilitate abortion access are to become a medical abortion provider. And there is a lot of information and resource on our website for professionals who are considering becoming this, including 3 modules on the intersection of domestic violence and what that means for medical abortion providers. You get to see me on YouTube for a few minutes there, being very earnest. Know the referral pathways for abortion provision in your area. Provide formal referrals and advocacy around those, and advocate for the option of long-acting reversible contraception insertion at the time of abortion provision as well. So we can end the pregnancy that's been coerced, as well as provide ongoing reproductive autonomy for that woman. Okay. I think I've mentioned this as GPs certainly play a very important role in those formal referrals. Some of the health and hospital service districts who are providing medical abortion through their sexual health services, women can self-refer, but if for medical reasons or if women are beyond the 8 weeks and 6 days mark, then a GP referral is a very central part to those referrals at this stage. So I hope from today's presentation, you can see that reproductive coercion has a far-reaching effect on the lives of women. Hope you remember that pregnancy pressure, contraceptive sabotage and pregnancy outcome control are the key strategies in this form of violence control, and that you now have some more skills and knowledge at your disposal to play the important role of enhancing women's reproductive autonomy through facilitating access to suitable contraception and abortion. I like to finish with this quote, which is one of my personal favourites, which is that if you care about intimate partner violence, you should care about reproductive justice, because a woman's reproductive capacity can be used by her abuser to assert further control as a component of all possible forms of abuse: sexual, physical, emotional, and economic. And that's from our good friends in the US, Jill Morrison from the National Women's Law Centre in the US. Here's some references, some light bedtime reading for you, if you care for that. There are other references on the trifold resource that I send out as well. Specifically, we tried to ensure that we referenced that document with research. And our contact details there. If you're after hard copies of some of those resources, you can certainly email us at advocacy@childrenbychoice.org.au. You can go to our website and make an online request for support, a formal referral as a healthcare practitioner to support a woman that you may be working with. And there's a whole host of other organisation, other information on our website, as I said, about becoming a medical abortion provider. There's our Know For Sure website, which is a youth-specific one that supports young people around disclosing unplanned pregnancy and seeking support. And our counselling numbers there online for you as well.
Thank you so much, Liz, for such a thoughtful and insightful and thorough presentation. That was really valuable. We've had a couple of questions come through. We'll have time for a couple now. Liz, for health practitioners who are working with patients who haven't disclosed a reproductive coercion, what would you recommend as some of the signs or patterns that health practitioners could be really aware of in identifying that where a patient hasn't disclosed?
Reproductive coercion. I certainly think the most obvious one would be any nervousness or hesitation around contraceptive counselling. So if we're asking them, we're routinely asking about, well, what are you doing for contraception at the moment, and we're coming to a conversational dead end, that certainly can be a flag that there's some significant discomfort there. So that would be before a pregnancy is in play. Women coming to them with regular, as I said, STIs and UTIs would be an indication that they're not in control of some aspects of their sexual health, and certainly looking at those facing unplanned pregnancy and abortion. So a simple obs-gyne history certainly will flag domestic violence as well as reproductive coercion. If there are previous abortions, if there are previous miscarriages, and if there is rapid repeat pregnancies and children close together, then those are certainly things that can flag for us that this is a woman who's not necessarily in control of her fertility.
Thank you, Liz. And we've just had another question. You mentioned in the presentation a journal article that you'd recently published, your team, and is that publicly available to be shared?
It is publicly available. We'll probably pop it on our website, I think. You can Google it through the International Journal of sorry, I can't say it, all the words are gone. The International Journal of Interpersonal Violence, but I think what we'll take away from today is we'll get our comms worker to put it on our resources list on our website where it can be accessed more easily.
That'd be great, Liz. And if you can also send that through to us, we can share that with everyone who's attended today as well. It's 1 o'clock now, so we might have to wrap things up there. I would again like to thank you, Liz, for taking the time to share all of your knowledge with us today. Really appreciate it. And for anyone who would like to share this presentation with colleagues or to watch it again, it will be available on our website, and we will email that out to you as well once it's available. Thank you so much, everyone.
Thanks, folks. Bye-bye.